All right, today we're jumping into some of the biggest challenges in orthopedic trauma: traumatic hip dislocations and acetabular fractures. These are not your everyday breaks. We're talking about massive, high-energy injuries that can completely change a person's life and really demand that we know our anatomy and surgical strategy cold. So let's get right into it with a classic mechanism, one you absolutely have to know. What exactly are we talking about when we say a dashboard injury?
Yeah, this is your classic high-energy trauma, right? The kinds you see in a bad car crash. Imagine the knee smacking the dashboard. That force has to go somewhere. It shoots right up the femur like a shockwave, and bam! It just slams the femoral head straight back, blowing out the posterior wall of the acetabulum. You can even get what we call a central dislocation, where the head is literally shoved right through the socket and into the pelvis.
Okay, so if we're going to have any hope of fixing these things, we've got to master the surgical anatomy. And believe me, the acetabulum is not just some simple cup. Its unique architecture is everything. It dictates our entire game plan.
So here's the key. The way you have to think about this surgically, you've got to see the acetabulum as two massive pillars or columns. You have your anterior column, made up of parts of the ilium and the pubis, and then you have the posterior column, which is part ilium and part ischium. Seriously, this two-column concept, it's the absolute foundation for everything we do. How we classify the fracture, how we plan our surgical attack, all of it.
And it's not just the two columns. There's this other really critical piece of the puzzle, the quadrilateral surface. Think of it as that thin inner wall of the acetabulum. Now, why does this matter so much? Because when this part is broken, it is a real beast to fix. And its involvement almost always pushes you towards using an anterior surgical approach.
Okay, so we've got the anatomical framework down. Now for the big question, what do we do about it? Once we know the fracture pattern, it really comes down to a fundamental choice. Can we manage this conservatively, or are we heading to the operating room?
Now, you can manage these conservatively, but let's be clear, this is a pretty small group of patients. We're talking about fractures with basically zero displacement, or maybe patients who are just too sick for a big surgery. But, and this is probably the most important point here, if that hip is dislocated, you forget everything else. That is an orthopedic emergency. It needs to be reduced, and it needs to be reduced now. But honestly, for the vast majority of these, if there's any significant displacement, we're going to the OR. It's a standard of care, period. Our goal is twofold. We want a perfect anatomic reduction, and we need to lock it down with some serious hardware, usually plates and screws. This isn't just about making the bone heal. It's about giving them a perfectly smooth joint again to prevent that crippling arthritis down the line, and, just as important, to get them up and moving. So we've decided to operate. Now, how do we get in there? This is all about choosing the right pathway. And the beautiful thing is, the fracture pattern itself tells you exactly which approach to take. If your fracture is in a front, we're talking anterior column, anterior wall, or that tricky quadrilateral surface, the STOPPA approach is a fantastic tool. It's an intrapelvic approach, so you're basically coming in from the inside, which gives you this amazing direct view of the entire front of the joint. It's a really elegant solution for these specific patterns. On the flip side, for those posterior injuries, your classic dashboard type, the go-to, the absolute workhorse is the Kocher-Langenbeck approach. You're coming in from the back, and it puts you right where you need to be to fix that posterior wall or column. It's the most common approach for a reason. But, and I cannot say this loudly or emphatically enough, when you do a Kocher-Langenbeck, there is one rule that is absolutely non-negotiable. You must find, see, and protect the sciatic nerve. It is sitting right there in your surgical field. Hitting that nerve is a catastrophe, a devastating, life-changing complication for the patient. You have to be meticulous every single time. Okay, let's pull all this together. What are the big things you need to walk away with? The clinical pearls you can actually use when you see one of these complex injuries roll into the ER. So here they are, the top 5 things to burn into your brain. 1, have a high index of suspicion with any high-energy mechanism, especially that dashboard injury. 2, know that two-column anatomy inside and out. It dictates your entire plan. 3, a hip dislocation is an emergency. Reduce it now. 4, let the fracture tell you the approach. STOPPA for the front, KL for the back. And number 5, and I'll say it again, the sciatic nerve is your responsibility. Protect it at all costs. So there you have it, the core principles for managing these incredibly tough injuries. But I want to leave you with one final thing to think about.
We can do a perfect surgery, get a beautiful looking x-ray, and that patient can still go on to develop awful, debilitating arthritis. So the real question for the future is, what's next? Could emerging treatments like biologics be the game changer we need to really improve the long-term outlook for these folks? It's a critical question and definitely something to keep an eye on.